You guys can go ahead.
Okay, let's look at neural tension in the lower extremity using surgical tubing as kind of a primitive way to depict the path of the sciatic nerve branching into tibial nerve. So I know the tibial nerve goes through the tarsal tunnel here. I'm just having a hard time keeping it there with my rubber band, so I'm going to put it on the back of the ankle just so you can tell that dorsiflexion is going to, dorsiflexion is going to increase the tension of the nerve in that part. It's going to go up through the back of the knee in the popliteal area, go up near piriformis in the rear end around ischial tuberosity into the lumbar spine area, and then if we think about the dural membrane throughout the course of the nerve all the way up to the skull and the brain, right? So again, a general depiction of this sciatic nerve, tibial nerve in lower extremity would be, you can say there, would be a relative straight leg raise. So I'm tensioning it through the hip, tensioning it through the back of the knee. I can add in some ankle dorsiflexion since this goes behind the axis of the ankle in the tarsal tunnel. That would be neural tension. If I backed off with her ankle component, it goes on relative slack, as you can see. And if I tension her here, let me keep this in her tunnel. There's her tension with dorsiflexion. It's much more taut in this position. Again, I can add a little bit of tension, hard to see on the model here, but if I bring her through slight adduction, introtation of her hip component, it's going to wrap that nerve around the ischial tube, adding a little bit more tension. Therefore, this is going to put it on slack. All right, so if I bring her up into her tension position, what often we do with patients then, if they're getting some symptoms into their leg, is I'll ask the patient to gently lift their head up off the table, flexing from above, so we're putting the whole dura on more of a stretch, thinking around the cranium and the cranial components of the dura all the way into the cervical spine and down. You can rest your head back down. So in some cases, that neck flexion increases the symptoms, which is a true sign of dural tension. In other cases, when the patient lifts their head up like that, they'll say, oh, that's weird, my leg doesn't hurt anymore, and it decreases their symptoms. So when I put her on more tension, it actually relieves the nerve pain in her leg. So let's talk about that a little bit, why that might be the case. You can rest your head back down.
Okay.
So most of us can follow the fact that when we go through this straight leg raise position with ankle dorsal, we're putting this sciatic nerve tibial component on stretch. In some cases, I'll show you in the spine model here, right? When I tug on the nerves in her leg, just use this area here that I'm grabbing, the nerve's going to kind of pull out of the foramen slightly, millimeters we're talking. Let's say there's an area on the spine that has some scar tissue or some, I'll say foreign tissue, usually it's scar tissue, adhesions like that. So when I pull the nerve from below, the yellow nerve is kind of hitting or abutting onto that green adhesion piece of scar tissue, causing pain down the leg. When the patient then, while the leg is on stretch, if they go then and flex from above, they're pulling that sheath back in centrally, creating space and decreasing that tissue on here. So think when you just pull from below, you might be hitting a structure in the area. The patient then, by lifting their neck and flexing, pulls it back the other way and takes that pressure off the adhesion nearby that nerve root. Okay, great.